One of the GI surgical oncologists at our cancer center and part of the carcinoid neuroendocrine program. And what I'm going to do today is do an overview of management of small bowel carcinoids, focusing quite a bit on imaging, what's new out there. And then I really also wanted to give you a flavor of some of the research that we're doing on our patients at Cedars that's now being presented nationally, so to give you an idea of what's new out there in terms of management, prognosis, and hopefully open it up for questions. I don't mind if you wanted to interrupt me and do questions at that time as we're going through, because sometimes people forget at the end, but however you want to do it, I'm totally fine whichever way you want to do it. All right, so in terms of small bowel carcinoids, so primary small bowel malignancy, just so you know, there's about between 9,000 to 9,500 cases a year. So that number continues to go up every year, and that's just small bowel cancers in general. GI neuroendocrine tumors are the second most common GI malignancy. And I'll explain to you what the GI tract is after colorectal cancer. So just so you know, the incidence is increasing quite significantly. We don't know if it's just because we're better at diagnosing things now, and why it is that we're seeing it much more than we did several years ago. Over the last 30 years, small bowel neuroendocrines have now become the most common small bowel malignancy, and it's surpassing small bowel adenocarcinoma, which is it used to be the most common small bowel cancer. So much like colon cancer is colon adenocarcinoma, pancreatic is pancreatic adenocarcinoma, which are the more common cancers. Small bowel adenocarcinoma used to be the most common cancer, and now small bowel neuroendocrine tumors have actually surpassed the incidence. So if you look at the incidence of small bowel tumors, when you look, so adenocarcinoma, which used to be the most common, carcinoid now is the most common disease site for small bowel tumors. When you look at where it is that small bowel tumors occur, they can occur in the duodenum, which is the beginning part right after the stomach, the jejunum, and the ileum. But if you look at the different kinds of tumors that you can get in the small bowel, adenocarcinoma still remains the most common cancer in the duodenum, also in the jejunum, but in the ileum, carcinoid is really the most common cancer. And if you look on this chart right here, the incidence of carcinoid, which is the green line, is increasing very rapidly. Now, the incidence of neuroendocrine tumors, if you look, lung, small bowel, and rectum continues to increase exponentially. And it's predominantly, and when we refer to small bowel carcinoids, it's really the ileum that we're referring to, because that's really the most common site. When you look at the incidence of small bowel neuroendocrine tumors, the tumors in the colon and the appendix are really kind of leveling off. But if you look at the small bowel and the rectum, as well as lung, those are the three tumors, the neuroendocrine tumors, where the incidence is continuing to go up. So majority of the neuroendocrine tumors arise from the GI tract. So it's about 54%. When we refer to the GI tract, I'm not referring to pancreatic. I'm just referring to the bowel, the stomach, the rectum. The most common GI site still remains the small intestine. And within the small bowel, neuroendocrine tumors are predominantly in the ileum. So just to give you an idea of what the GI, when we refer to the GI tract, so this is liver. This yellow right here is the pancreas. This is the stomach. The stomach, where the stomach ends, is the beginning of the small intestine, which is the duodenum. This is all the small bowel. We've got 20 feet of small bowel. And then the small bowel ends right here. So this is what we call the terminal ileum. And this is the cecum right here. When we do colonoscopies, this is how those incidental carcinoids are discovered when somebody undergoes a colonoscopy. When you're doing a colonoscopy, you get all the way around here in the colon, you come all the way down to here. And most gastroenterologists will actually stop as soon as they see this area right here, because they'll see the lumen of the appendix. So this is the appendix coming off the cecum. And several gastroenterologists will stop as soon as they see that. It's the few that go the extra mile and go a little bit beyond that valve. So that's the ileocecal valve. Well, they'll go right through here into the small bowel. And it's actually within that 2 centimeters is where terminal oleocarcinoids are found. So it makes a significant difference, because just remember, otherwise small bowel carcinoids are found much later, and it's purely because there's no real good way to find them. So keep in mind, it's really, this is the area where they occur. And then when we refer to foregut, midgut, and hindgut carcinoids, so these are the foregut carcinoids. The midgut is the ileum, jejunum, appendix, and the colon, and then the hindgut is the distal colon right here and the rectum. So in terms of how patients present with carcinoid tumors, if you look, for most of them, for rectal, they present with rectal bleeding, constipation. For the lung carcinoids, they present with recurrent pneumonia, cough. They can present with hemoptysis, which is blood in the sputum. Appendix is also found incidentally. These are patients who undergo an appendectomy for presumed appendicitis, and then carcinoid is found in the specimen. Stomach carcinoids, gastric carcinoids are usually found for when patients undergo a workup for anemia. But small intestine, it's unusual. Most of my patients have really had years of intermittent abdominal pain. They've seen gastroenterologists, they've had scans done sometimes, and no one's really known. It's just intermittent abdominal pain, bloating. What's important to know is that most of our patients still present with metastases when it comes to small bowel cancers, purely because there really isn't a great way to diagnose them. So in terms of clinical presentation for small bowel NETs, most patients present with several year history of intermittent abdominal pain. They'll have diarrhea. They'll have a colonoscopy done for the diarrhea, because the gastroenterologist thinks that's why they're having the diarrhea. It has to be something in the colon. But it's really the small bowel lesion that's causing it. They rarely bleed, unlike the gastric carcinoids. The gastric carcinoids, they erode the mucosa, so the patients there present with anemia. So small bowel carcinoids rarely bleed. But how they do present is obstruction. Part of it is they go unrecognized for years and years, and then they continue to grow. And the lumen of the small intestine is much smaller than the lumen of the colon. So it causes obstruction. What's also important is carcinoid syndrome, obviously, as you know, all implies liver metastasis, but it is much less frequently for these patients. What's important to know about these is when patients come to see me and they say, well, it was a 5-millimeter cancer only seen on colonoscopy. What's important is the ability for the tumor to metastasize to the liver is not based on the size of the tumor. So tumors less than 1 centimeter have about a 15% chance of metastasizing to the liver, so presenting with liver mets at the same time. If you have a tumor that's between 1 to 2 centimeters, the risk is about 50 to 60% of having metastatic disease. What's important to know is that for about 30 to 50% of patients, they don't present with the primary tumor. They actually present with metastatic disease. So they undergo an abdominal scan, and then liver metastases are found. It's biopsied, comes back as neuroendocrine tumor. Now you've got to figure out where it is. So most of these patients do present not localized, but with metastatic disease. And usually the small bowel carcinoid itself is usually not detected until the metastatic disease is developed. So commonly, these are in the last portion of the small bowel, so the last 60 to 80 centimeters. Rarely they can occur in the proximal ileum and jejunum, which is why we study patients a lot more than that. And they're diagnosed by core needle biopsy, and this is usually of the liver metastases or the primary lesion. And on pathology, they look for specific stains, and that's how they're able to differentiate adenocarcinoma from carcinoid. You do chromogranin and or synaptophysin, and that confirms that it's a neuroendocrine tumor and not an adenocarcinoma. So when you look at serum tumor markers, so this is the blood work that's always measured when you come in for your follow-ups as well. Chromogranin A really remains Chromogranin A is really the test that has the highest specificity in terms of diagnosing. So if you suspect somebody has a neuroendocrine tumor, or you've you've diagnosed it in terms of biopsying a metastatic lesion, it's really the most helpful test for a known neuroendocrine tumor to confirm it. What's important to know is that there are patients out there who have no neuroendocrine tumors that can have an elevated chromogranin A level. And those are patients who have really uncontrolled severe hypertension, renal insufficiency, patients who are on PPI, so these proton pump inhibitors, that's protonics that people take, Nexium. If you've been on chronic therapy, you can have an elevated chromogranin A level. Patients who have inflammatory bowel disease can also have an elevated chromogranin A level. What's important is to follow the trend of it. It's a great marker for response to therapy. So after surgery, getting another chromogranin A level done. If you had chemoembolization, PRRT, in general, all of those, it's a good way to know a response to treatment. But what's important to know, it doesn't always correlate with symptoms. So someone who has really significant symptoms with diarrhea and flushing cannot have a very high chromogranin A level, and you can have patients with very high chromogranin A levels but not have that many symptoms. So it doesn't always correlate. Pancreatic polypeptide is the other one that we do follow, and that's got intermediate specificity, but we do follow that for several of the neuroendocrine tumors besides small bowel. 5-HIAA is also a great test. It's helpful for the midgut, which is a small bowel. It is not elevated in the thymic, the lung, the gastric carcinoids. Carcinoid syndromes and very high 5-HIAA levels really suggest liver involvement. And if you have a 5-HIAA level that is greater than 1,000, there's a high correlation between elevated levels as high as that and patients developing carcinoid heart disease. What's important to do this when you are doing these urinary 5-HIAA levels, just remember it can be falsely elevated, and this is with ingestion of fruit, and that's bananas, kiwis, pineapple. Nuts is pecans and walnuts, can also cause a falsely elevated level. So you want to be very careful when you're getting your 5-HIAA levels to avoid a lot of these things because they can cause a falsely elevated level. Chromogranin A level is what we follow patients with, and it's basically a great test to trend response to intervention. It's important, it's the trend and not just one single reading. So if you see a slightly elevated level, we'll get another one to make sure that it's either trending up or whether it was just falsely elevated. What's important is that you get the test done at the same labs. Every lab has a control, and it can be different at different labs. So Quest, Cedars, everywhere has a different lab. So if you're being followed, just make sure you're getting it done at the same laboratory test so that this way the trend can be correlated much more. So now let's go to imaging. We know there's blood tests, but how do we make the decisions that we do when it comes to surgery, no surgery, doing chemoembolization, before doing surgery? So it's just all those things. How do we, in our multidisciplinary conferences, make these decisions? So the first thing is always we want to have some modality of imaging that can find the primary tumor. The second, we want to see if it goes to lymph nodes. Cancers like to go to lymph nodes. That's what carcinoid likes to do. And then obviously the other place, which is it likes to end up in the liver. So how do you find one good imaging that's going to be able to help find all this for us? So there's two ways we approach things. The first is there's anatomical imaging. Anatomical imaging is really where the adjacent structures are to the tumor itself. Functional imaging doesn't tell you anything about anatomy. So octreotide scans, PET scans, the gallium DOTA-PET don't tell you anything about the anatomy, and I'll show you what I mean by that, as opposed to ultrasound, CTs, and MRI. So ultrasound, CTs, and MRI give you the true anatomy. So you can see a tumor, and you can see the adjacent structures, blood vessels around it. With all the other scans, it's really you're injected with an isotope that's taken up by the tumor. We know the tumor takes up this isotope, and it's very predictive of neuroendocrine tumors, and we know it's in that vicinity. But you can't always use this to really tell exactly where it is. So I'll show you with Octreotide Scan. Sometimes it just lights up in the middle of the abdomen, and you don't know if it's in the lymph nodes or if it's in the bowel. So it doesn't really give you anatomy, but it tells you that something there with good confidence that you at least have. And that's the difference between anatomical imaging and functional imaging. So in terms of ultrasounds, Ultrasounds aren't really great tests for looking at much in the abdomen, except when it comes to things like the duodenum, the stomach, and the rectum. So we do ultrasounds, in a sense, for those, because if you look right here, you can actually biopsy with these special endoscopic ultrasounds that we have. So you can do a fine needle biopsy to get tissue to get a diagnosis. If someone's getting, if there's a suspicion for a rectal carcinoid, we usually do a rectal ultrasound in addition to when we have somebody diagnosed. And that helps us also figure out if there's lymph nodes involved and gauge the extent of disease. So that's really the main reason we do ultrasounds. We do have patients who sometimes get an ultrasound of the abdomen that's performed because they've been having unusual symptoms for years, and their primary care doctor will get the ultrasound of the abdomen, and lo and behold, they see something in the liver. But it does not give you anything else in terms of the GI organs itself. So it's not a real ideal test. It's usually used as an adjunct. So how about CT scans? You know, when you come in, it's a matter of, do I get a CT scan of the abdomen? Do I get a CT scan of the chest? Do I get an MRI? Which is the best test that's going to give us the biggest bang for our buck? The reason most people get CT scans, first of all, it's readily available at every hospital. It can detect lesions 1 millimeter or more in size. It's great for looking at lymph nodes. And the great part about it is you can survey multiple sites. So you can look at the liver, you can look at the small bowel, you can look at the lymph nodes. It's a great test from that standpoint. It's not that great at looking at the liver compared to MRI. So just to give you an idea, this is one patient who presented with a known carcinoid. So this was found on routine colonoscopy. This is the terminal ileal carcinoid right there. Okay, so that's the lesion right there. This gives us it gives me a lot more imaging. So number one, so just to give you an idea, this is the liver. So this is metastatic disease in the liver. Now these are big lesions, so obviously much easier to see in the liver. And then right here, this is what we call the mesentery. This is where all the lymph nodes live. So it gives me an idea in terms of a roadmap when I'm deciding which way to approach these patients, and when we present them at our multidisciplinary group. Do I do surgery first just on the primary? Do we take out the liver lesions at the same time? So it gives you a lot of information that we need. The disadvantages, one, is obviously radiation involved in doing CT scans. Patients do have contrast allergies. You cannot do these scans. CT scans don't give you much information if you're not using the IV contrast. So that's what helps distinguish a lot of the lesions that we see. You can't do it if you have any renal dysfunction. So if you have problems with your kidneys, you can't, because the contrast does affect your kidneys. And it's not great for visualizing small bowel lesions. So if you have a patient who had a routine colonoscopy done and there was a small lesion found right when the gastroenterologist passed that scope and he biopsies it, very hard to just see it on a CT scan. So not a great test for picking up small bowel lesions. Sorry, I should have figured this out. So what about MRIs? MRIs, one advantage, no radiation at all. Okay, so just so you know, it's actually even safe to do in pregnancy, MRIs. It's great for patients who have contrast allergies because you don't have that side effect from using the barium that they inject you with or to do this. It's a better way to visualize liver lesions than CT scans does. And here we used a contrast agent called Eovist, which is really great at picking up lesions. With CT scans, a lot of times you will pick up liver lesions and they're not sure if it looks benign or malignant, and a lot of times we then have to go forward and do an MRI to better characterize the lesion, and I'll show you in the next patient how that happens. So this is a patient who had a CT scan done initially that showed 2 lesions in the liver. So there's a lesion right here, and there's a lesion right here. So this is the MRI though. So MRI gets done, and this is why MRI is great at figuring out. You're given a contrast agent, and it's excreted, it's transferred to the liver through the artery and then excreted in the veins. Now if you look, so this is the arterial phase and this is the venous phase. And this is how we can differentiate something that is cancer from something that is not cancer. So here we have 2 lesions that have taken up contrast. If you look here, it's excreted out by this one. This is how we tell that's benign and this is not. Okay? This is actually a hemangioma, which is a benign blood vessel. It's a collection of blood vessels in the liver. This is the cancer. So it's a great, MRI is really, for looking at carcinoid to the liver, is really the best test rather than CT scans of the liver.
Can I ask a question?
Sure.
Are those hemangiomas, are those real commonly found?
Very commonly found.
I mean, so even people that don't
yeah,
have
we
cancer,
have so
it's
many
just-
patients who end up in the ER who get scans when they've had a car accident, and they get scans and they get hemangiomas. So it's very common to get hemangiomas of the liver. The disadvantage to MRIs, it's a longer imaging time. CT scans are really 10 to 15 minutes. You can almost scan from head to toe. MRIs is about 40 to 50 minutes for MRI, so it's much more longer. It's much more expensive than getting a CT scan. It's limited availability because the contrast agent, the EOVIS, which is great at picking up these lesions, is not readily available at all institutions. So that is the advantage. And the other thing, much like CTs, it's not great at looking at small bowel lesions. So we don't use it as a staging for when I see a primary small bowel. We do get it just to rule out liver disease, but I don't get much information in terms of the local disease, because the MRI just helps me figure out if there's liver disease involvement, so it helps me plan the surgery much more. Yes?
One question, in the skeleton of the MRI, is it helpful in the skeleton, or is the CT more helpful?
CT's probably, I mean, you could see both, like the bones, you can see with both CT and MRI. So the Octreotide scan. So now I'm going to go to more of the non-anatomic and the functional imaging. So Octreotide scan is really the scan that we use for diagnostic purposes. So when someone has elevated tumor markers, we know that there's a neuroendocrine tumor, can't find it, or patient has symptoms and you have a primary care doctor who's got the tumor markers that suggest that this is one way of finding things, is the Octreotide scan. So it's an injection, as you know, it's done over you have to come in multiple times to get the scan done, so you're injected and then you come in several days later. So it really just relies on the physiologic differences between the primary and the surrounding tissue. So it is really takes a radioisotope that is taken up by tumor. So that's what all these PET scans, the DOTA PET, and Octreotide in general, they're all a radioactive material that is injected, that's radio labeled, that is picked up by this. Octreotide scans are really for neuroendocrine tumors only. And obviously, it's only going to be positive if your tumor has somatostatin receptors. We've done Octreotide scans on patients where they don't express, they don't have somatostatin receptors, so that their Octreotides are completely negative. So the scan isn't that helpful. We do know the Octreotide, it's more specific for neuroendocrine tumors. It's great at looking for extra-abdominal metastases. So yes, it looks at the liver, but the great part is you can have it lights up in bone. It can help you figure out a lot more things when it comes to staging. And the great part about Octreotide is also used for treatment response. So it's for patients who've undergone PRRT. That's one way that they assess treatment response, besides the gallium DOTA PET that I'll show you, is also the Octreotide. Yes?
Is it possible to have a positive Octreotide scan and not have I had something light up on my Octreotide scan, and then some doctors are saying, no, you can't count on that.
So it depends where, because you can have it, I've had it where patients have had it falsely elevated in the thyroid, for instance. And what we do is
and then you've had a flexure.
So usually not. Usually not. So it really depends, because if you just have an Octreotide scan showing something, then what you need to do is, it doesn't, like I said, it doesn't give you anatomy. It's only gonna light up, it's almost like skeletal images, and you see a blip on a scan, and now what you've got to do is try and figure out where it is. So if you see something on an Octreotide scan that lights up, then you've got to do more imaging, which is the anatomic imaging now. So you now have to either do a CT or an MRI to make sure that what you're seeing is nothing or something. Same way, if it lights up in the thyroid, the next best test is not a CT scan of the neck, but it's really an ultrasound of the thyroid. All right, so how about the gallium DOTA PET CT that everyone has heard about? So these are obviously the scan that has the best resolution. It gives you the best functional imaging, and purely because this has the highest avidity to the somatostatin receptor 2 and 5. It is very effective at detecting very small tumors and metastatic disease, extremely small disease. It's very safe. It has less radiation than an octreotide scan. You also don't need 3 trips. There's only one 90-minute scan that's done. And it's also great at monitoring treatment response. The disadvantage is obviously it's expensive. Well, there's very few places in the United States that have it. I think Stanford is the only place that has it right now. I don't think UCLA is still, and then Texas is. So it's really, there's very limited places that do have this. The other part is similar to the octreotide, you can have false positives, and it's usually the false positive places are the spleen, the thyroid, and the adrenal gland. And usually if you do have that, you have to also resort to anatomic imaging, so get a CT scan or an MRI to make sure that there isn't disease there. So you can't just assume that just because it's falsely positive that you're not going to follow it up. It's important to get another scan just to confirm that. So this is how the gallium DOTA-PET works. This is a regular octreotide scan. Yes, we see something here. We see something, this right here. But this is what the same patient, this is the gallium. So you see so much more disease that you really cannot see on the standard octreotide.
Farin?
Yes.
Can I ask you- So is that difference because of the affinity to the receptors?
Yeah, because of the
too?
receptors.
I thought
In
that's
addition,
why-
it has the ability, the resolution is so much better at picking up extremely small disease. Octreotides do not.
But octreotide also attaches to receptors too?
Yeah, but not 2 and 5.
Oh, if it's not 2 and 5?
Correct.
Oh, that's.
Does lanreotide do it?
Lanreotide,
Yeah, will it pick 2 and 5 up?
yeah,
It will.
it will. So that's really why the gallium DOTA-PET is really the test that everyone wants to get, purely because it can pick up small disease. For patients who are being evaluated for things, for instance, for a liver transplant, this is the test you want to get because you want to make sure they don't have disease outside of the liver. And this is the test that's going to be able to prove it. Yes.
So does that mean perhaps that lanreotide would be a
Well,
stronger medicine to?
Well, it is, so the reason the
Injection.
DOTA-TAP, they
Okay.
both do. They both have affinity for both receptors.
Right.
But this, the gallium has a higher affinity towards receptor 2 and 5 than sandostatin does,
Okay, I'm
which is the
thinking in
octreotide,
terms-
the treatment.
Okay.
Yeah, so lanreotide and sandostatin both have the same, but this is just in terms of the scan itself and the radioisotope that is being injected. So it's the radioisotope that is being injected has a higher affinity in the gallium scans for somatostatin receptor 2 and 5 than the octreotide scan, than the pentatreotide that's injected.
Knew how my mind was working.
Yes.
With the gallium scan, if you had the gallium 68 and it came back negative, is it then necessary to go ahead and have an MRI and CT also? Or is that, if you're clean here,
Yeah.
is that a good enough reason to avoid the other?
Sure, just for that time period, you could, but you just have to make sure you keep getting the surveillance imaging. Yeah, because you still have to get repeat imaging, so I'm not sure if you can continue to pay for these every 6 months. So in terms of imaging, again, just to summarize, CT is really kind of the best initial test. MRI is the best at looking for liver metastases. That's really why when it comes to future surveillance. So most patients get a CT at the beginning when they come to us, but for follow-up, the best test that we are using is MRIs to follow the liver rather than the CT. And really functional imaging really just confirms neuroendocrine and helps us show metastatic disease outside of even the area that we're doing. So once we know, so for instance, if someone has something that lights up on a octreotide scan, what else can we do to localize things much better? So we've got this whole list of things that we can do. We can do CTs, MRIs, like I showed you, endoscopic ultrasounds, double balloons, capsules. I'm sure some of you have gone through these. But just to give you an idea, so some patients come to us with an upper GI small bowel follow-through looking for a small bowel carcinoid. I don't think I could find anything on this. So this is contrast, and people are hoping that if it's done well enough, you may be able to find a filling defect in this. Hard to pick up because it's really, this is to look for very tiny small bowel tumors. Very hard to believe that you could see something in an upper GI small bowel follow-through. So not a great test. It's great at picking up things like obstruction. And as you can see right here, so this is the contrast coming through. And for this patient right here, this whole segment was involved with carcinoid disease. So there were multiple carcinoids, and as you can see, the whole lumen is completely narrowed. So this is how you have obstructive symptoms when I say that things start to back up and block. So if you see, this is the lumen, and you can see how narrowed it's now becoming. So things are going to have much more difficulty passing through. So bigger disease, yes, they'll pick it up. But really small lesions, which is what small bowel carcinoids are, really difficult to pick up on these. So octreotide, for instance, just to give you an idea, when we say, if you look really closely here, this is an area that lit up on this patient's abdominal area. I can't tell if that's small bowel or mesenteric. Nobody can, actually. So here, this is a patient who had liver metastases. We did an octreotide, we had elevated tumor markers, so the next test was the Octreotide scan. We know it lit up here, and now we've got to figure out, obviously, is it small bowel? Is it the mesenteric mass that we're seeing? So this is why Octreotide scans are great, but they can't really differentiate this part, the intestine and the mesentery. So how about capsule endoscopies? Capsule endoscopies is really a camera it's a pill cam, that's what we call it, and you swallow it. It goes very nicely through your bowel. It glides through from the stomach all the way down, and you poop it out, basically. And that's how as it's traveling through from your mouth all the way to your anus, it continues to take pictures all the way through. So it's great at detecting small bowel lesions less than 1 millimeter in size. So this is a great test in a sense where if someone presents with bleeding, has diarrhea, you're not sure what it's from, capsule endoscopy is a great test to look at things like that. It can detect about 60% of primary lesions, so just remember it does pass through things fairly quickly, so it can pick up things, but it can miss things as well. The pill is really given after an overnight fast. You don't have to get cleaned out to do it, so no bowel prep, and it's naturally excreted. And it yields it's similar to getting an Octreotide scan. So this is a patient of ours who had one done with the pill cam, and that's the lesion right there. So double balloon enteroscopy is probably what we've now replaced a lot of the capsule endoscopies with. So colonoscopies are where you go through the entire colon and you go through here. You cannot, and you go to the beginning part of the small bowel. So you can get up to about 5 centimeters of small bowel. You cannot go beyond that. So you've got all this small bowel that you've got to look through, which is important when you've got small bowel carcinoids, and I'll show you why. But 40% of patients have multifocal disease. So yes, you can have a lesion here. How do you know there's not something further back here? And that's what double balloons are really great at doing. So it's a 2-stage procedure. There's an antegrade and a retrograde. A retrograde is this one right here, where you go from the rectum, the scope goes all the way around and goes into the terminal ileum. Right where they reach in the small bowel, and it's usually the proximal ileum, there's a tattoo mark placed by the gastroenterologist. So that's the tattoo mark right there. It's black ink that they inject into the wall. That's the only way they know how far they've gone retrograde, because they've got to look at the entire small bowel. And then the second part of the procedure is a scope that goes from above all the way through, and they've got to find that tattoo mark to know this is the extent, and we've looked at the entire small bowel now, and there's no additional lesions. The great part about double balloons, as opposed to the capsules, is the double balloon you can biopsy at the same time. So if you see something on the double balloon, you can biopsy it that very day. If you do a capsule, you can't biopsy it. All it's doing is taking pictures as it goes through, and then you've got to go through this procedure to get a biopsy done. So here's a patient, double balloon. This is what you see right here. These are small little lesions that looks very big because it's magnified, but they're fairly small. And then this is other way you can pick it. It's a bulge from the outside into the lumen. So the way it's done, obviously, you fast the night before, and you have to do a bowel prep for this purely because they have to see very small lesions and they have to biopsy it. You have to go undergo anesthesia for these procedures. And it's great for tissue diagnosis and also for marking. So for instance, for me, I do a lot of these procedures laparoscopic. And one way to do this to make sure that we have the primary is the gastroenterologist will tattoo the area with black ink, so I know exactly the extent of where we need to go when it comes to surgically doing this, because you lose that ability for tactile sensation when you do things laparoscopically. And then just remember, the way we look at it is suspicious lesions. Now just keep in mind, this is when the gastroenterologist does that, they're looking at the outside, the inside, right? When we do surgery, we found things on the outside of the bowel. I always tell patients, yes, it's great, your double balloon was negative, there's one lesion that we know of, but there's always a risk that we can find things on the outside. And the outside part is what the surgeon sees, the inside part is what the gastroenterologist sees, because carcinoids can occur on the surface rather than on the lumen. So if you're doing things laparoscopically, how do you know? Because you can't feel, right? And these are very tiny. So before when we're finally doing our resection, we do make a small incision to pull everything through. And through that, the small bowel is very loose in the abdomen, unlike the colon that is fixed to the side wall. The small bowel, as soon as you make an incision, you can eviscerate the whole thing out of your abdomen. So we actually still run the bowel to make sure that we're not missing anything on the surface of the bowel. I know Dr. Lowe's group has gone through and looked at the inside. I need to make sure there's nothing on the surface. I can't just assume that it's negative. So we always do that, even though we're doing things laparoscopic. You just want to make sure you don't miss something for a patient. So just to give you an idea of the multifocality issue, this is actually hot off the press. We're presenting this next week at our National Surgical Oncology meeting. So how has all these procedures really impacted our care of patients? Because a lot of our patients have come to us from elsewhere where they've had the small bowel surgery done by somebody else and they've never had all these procedures done. And should we be doing this on everybody? So we looked at our patients, so this was everybody who came to Cedars-Sinai over the last 6 years that had their workup done here, that had surgery done by our group, to determine what the true incidence of multifocality is. Should we be letting everybody out there know, if you're diagnosed with a small bowel tumor, what's the true incidence of finding additional lesions? Because most surgeons and most doctors out there in smaller communities don't know this. So as soon as someone's diagnosed, they're going straight to surgery and they forget that there's an issue with multifocality. So we looked at the incidence of it, the use of DBE, and to determine if there's actually a relationship between multifocal disease versus just one lesion on survival and recurrence. So if you had one lesion, is your chances better at recurrence and survival? Will you live longer than somebody who had 15 lesions in their bowel? So that's what we wanted to look at.
What is DBE?
DBE is the double balloon.
Double balloon.
So we did a retrospective review. We found 104 patients who were diagnosed between January and February of 2013, and all of them underwent surgery here at Cedars. So we looked at everybody. So these were, they either had a DBE done or they had a capsule endoscopy. So prior to 2007 and 8, we were doing capsules, and then we started to get the technology to be able to do the double balloons. Now, just to give you an idea, out of the 104 patients, of the ones who only went a double balloon, 62% of them had additional lesions found. 62% with only one lesion known had additional lesions found on DBE. And it varied between 2 additional lesions. So the standard deviation is 3.3. We had some patients who had 6 lesions found on DBE and had only 1 going in. So the main thing, yes, we find all these things and yes, we can take them out, but does it really affect outcome? When we looked at outcome, there really was no difference at all. So if you had 1 lesion versus multiple lesions, provided they were all taken out, your survival was the same. So you lived the same, regardless of whether you had 1 or multiple. How about recurrence? Even though there was a slight difference between unifocal, so if you have 1 lesion as opposed to multiple, there is a slight difference in terms of recurrence. It was not statistically significant at all in terms of final outcome. So it's good, it's important information to put out there. They do have a high incidence of multifocality. So yes, it didn't affect outcome, but remember it was because all of them were taken out. So if you know that they're there and you take them out, it actually improves outcomes. Obviously, if you don't know and you leave them in, it's a different story. So it's a valuable tool for detecting and diagnosing multifocal NET, but obviously it had no impact on patient survival. So how about location? Does where your carcinoid tumor actually affect your outcome? This was a paper our group published a year and a half ago on small bowel carcinoids, and we looked at the prognostic significance. Does it make a difference if you had a duodenal carcinoid versus a jejunal carcinoid versus a terminal ileal carcinoid? And we try to look at factors that contribute to survival. So we looked at the SEER registry, and this is almost 11 years of patient data, and we looked at overall survival on these as well as disease survival. So you get a tremendous amount of patients. There's close to 3,700 patients who underwent resection for a small bowel carcinoid. Obviously, as you can see, ileum still remains the most common area where patients are diagnosed, rather than jejunum and duodenum. In terms of the extent of surgery, for duodenal, as you can see, local excision, most patients don't undergo major surgery for duodenal carcinoids unless they're big. Duodenal carcinoids, most patients can get an endoscopic resection rather than having a formal resection done. With jejunum and ileal carcinoids, a majority of patients had resection as opposed to local excision. And some of our patients underwent debulking, meaning they had simultaneous liver resections done at the same time, in addition to the local resection. When you looked at lymph nodes examined, it varied. As you can see, there were some patients who had no lymph nodes, and you won't get lymph nodes examined if you have something endoscopic, right? Because they're only taking it out from the inside. They don't take any lymph nodes out when you do an endoscopic resection. And they varied, obviously, in terms of the number of lymph nodes. So if you look, this was a study just looking at, does location really matter? Does it affect your outcome? And when we looked at this, yes, duodenal carcinoids actually end up doing better than jejunal and ileal carcinoids. So overall, there was a statistical significance. When you looked at disease-specific survival, meaning the disease coming back, duodenal carcinoids still did better than jejunal and ileal carcinoids. When we looked at everything, when we looked at patients, patient age, gender, race, the number of nodes that were involved, we didn't find any significant difference in the primary tumor site. When you factored in everything, the primary tumor location didn't become significant anymore. So in conclusion, yes, we saw that duodenals did have a superior overall survival and disease-free survival compared to it, but the primary site in and of itself was not a real predictor of survival. So it was taking into account everything else, not just location. And these were the other factors that we found that were significant predictors of survival. So it's the number of lymph nodes, the number of primaries, and the age of the patient. So this study kind of challenges the paradigm of the extent that location really doesn't matter. It was a predictor, but not really a true predictor of survival. And then one thing that we did learn was the extent of lymph nodes. There's no real mandate in terms of the number of lymph nodes that you take out. Just so you know, there are standards for all other cancers. So for colon cancer, a good colon cancer operation, NCCN guidelines, you have to have at least 12 lymph nodes taken out as part of your specimen. Otherwise, you did an inadequate surgery. For stomach, you have to have at least 15 lymph nodes in the final specimen. If you've had 4, that wasn't a good operation. There's nothing for carcinoid at all. There's no mandate for any surgeon out there on taking out lymph nodes, and we know it does affect outcome. And I'll show you that right here. So this was a recent presentation that we did on, does nodes affect a patient outcome? Is more better than leaving things in? So we looked at whether taking out lymph nodes improves survival, and we looked at the number of lymph nodes. Is taking out 1 to 6 lymph nodes better than taking out 12 lymph nodes? And we looked at the overall outcomes of these patients. So we had 2,796 patients who underwent surgical resection. And when you looked at survival, the number of lymph nodes taken out, yes, when you took out lymph nodes, patients actually live longer. If your number is less than 0.05, that's statistically significant. So although these lines may not look very close, it is statistically significant. So a p-value of less than 0.001 is significantly different. So yes, we know taking out lymph nodes really does make a difference. How about when it comes to looking at the different cancers? Does it make a difference? Because like I said, duodenal cancers, we don't take out lymph nodes for them because they're being taken out endoscopically, right? And you don't take out lymph nodes for that. So if you looked at patients who underwent a resection versus just an endoscopic, there was no difference at all. So it didn't really matter for that one. When you looked at jejunum and ileal primaries, it did make a difference. So these are patients where the blue line is they got lymph nodes taken out, and the green line they did not. And if you looked at the overall survival, patients who had lymph nodes taken out lived much longer than patients who did not have an adequate amount of lymph nodes taken out. So what about looking at the number of lymph nodes? Does that make a difference? Does taking out more better than is 1 to 6 better than taking out 10 or 12? So yes, it does make a difference. So this group right here, these are the patients who had more than 12 lymph nodes taken out. They had a significantly better outcome than if they had nothing taken out. A lot of times surgeons will take just a small section and connect things back together and not do a full lymph node dissection as part of the staging. So as you can see here, it did make a difference. If the more lymph nodes you took out, the better the patient, the better the patient did. So these are patients who had negative lymph nodes. So no lymph nodes were involved in the final. As you can see, they still lived longer than patients who had none taken out.
How many lymph nodes are there?
So, tons. I mean, you can do a colon resection and get 20.
So why wouldn't somebody take out a whole bunch of them?
No, it's interesting. We get a lot of patients done elsewhere where it's not, where they do just a lymph. And part of it is some of our patients present with bowel obstructions at outside hospitals. So it's being done as an emergency surgery. Surgeons go in, they make small incisions, and they just want to take care of that problem. They don't know what's causing it, right? Because a patient comes in with a bowel obstruction, you didn't know they had carcinoid. So you go in, you take that area out, you close it, and then 5 days later you find out they had carcinoid. Yes?
So the lymph nodes here they're always the lymph nodes in the lymphatic system that are proximal to where the primary is.
Is,
So
correct.
that's always, so it's
Yeah.
local, immediate vicinity.
Yeah, and that's how it is with all cancers, right? That's how for colon cancer, pancreatic cancer, that's how we make decisions about treatment. It's lymph nodes. If for colon cancer now, if you don't have lymph nodes that are involved, you don't get chemotherapy anymore. There's no indication for chemotherapy unless lymph nodes are involved. So taking out lymph nodes for this disease has never been mandated at all. It's not even part of NCCN guidelines to mandate it. So it does make
So would you say that they're behind the times?
They are behind the time. We're hoping this will put everything in, put things more into perspective. So we're really pushing that it really should be part of all staging now for carcinoids, where surgeons taking care of these patients really need to know that the extent of lymph nodes does matter just as much as it does for colon cancer and just as much as it does for gastric.
And I'm assuming there is no statistical importance beyond 12 plus?
Yeah, there really wasn't. 12 was really kind of the magic number. And really what we're going to do is hope that with a lot of the data that we have coming forth, that we'll be able to have more of a mandate now on the number of lymph nodes examined. So as I come to a close, I'm just going to talk to you about surgery itself. Surgery still remains the best chance at curing a patient with neuroendocrine tumors of the small bowel. Like I said earlier, 15% of tumors less than 1 centimeter have a risk of metastatic disease to the liver, and about 50 to 60% of patients with tumors greater than 1 to 2 centimeters have metastatic disease. Resection of lymph nodes is required. Now, you know, I have patients who come to see me and I talk to them about a prophylactic cholecystectomy, and they get really nervous about the idea of taking out something that doesn't have a problem. So I'll tell you how it is that we make a decision about taking out your gallbladder. When we do these surgeries, one of the reasons we do these surgeries is obviously, does the patient need sandostatin after surgery? If you do need sandostatin after surgery, there is almost a 25 to 30% incidence of developing gallbladder sludge and gallstones. And that becomes a problem because just remember, you're going to be on sandostatin for a long time. And the risk of developing these are high. And if you develop cholecystitis, which is an inflammation of the gallbladder, you need surgery. So in general, if there's any time that you suspect going into an operation that a patient is going to need sandostatin, and we know this a lot of times going into an operation, so liver disease, we know they're going to need sandostatin or some form of treatment after that. if they've got extensive disease. So when I go into surgery and I say, look, if I take out all the cancer, there's no data to show sandostatin is going to help you after that. So if all the cancer is out, I'm not going to take out your gallbladder. But if I know going into this operation that I'm leaving disease behind and sandostatin is going to take care of it after, I'm going to take out the gallbladder. So that's kind of the discussion of how it is that we take out, we do prophylactic surgery on these patients. Just keep in mind, every patient that has a one primary, about 30 to 40% of them will have a second, so it's important to look for them. And we do know that cytoreductive surgery, which is trying to debulk everything, including if a patient has liver disease, at the same time gives a patient a better chance of prognosis. What about non-surgical therapy? This is obviously for patients who have unresectable and progressive disease. We have shown, there is extensive data to show that sandostatin does help with that, and lanreotide. It's also used for symptomatic control. Octreotide therapy has been shown to lengthen the time to tumor progression and does improve overall survival. PRRT is now obviously being used quite a bit for patients who you have to have a tumor that does express sandostatin. You can't do it otherwise. So patients who are refractory to treatment. You know, chemotherapy, unlike all the other cancers, is not as useful, and it's purely because these tumors have a very low mitotic activity. Chemotherapy works for the high-grade neuroendocrine tumors, tumors that have a very high Ki-67. These are low-grade tumors, and that's why chemotherapy doesn't really work that well for this. Kind of the same way a PET scan doesn't show it. PET scans only show up highly dividing cells, which is how chemotherapy works. It works very well on tumors that are actively dividing quickly. And for liver disease, we obviously do wedge resections if we can do them simultaneously, lobe resections, and then chemo and radioembolization. So in conclusion, it's important that you have an expert team evaluating all these patients, kind of the same we always have been doing for all our patients on Monday. It's really trying to figure out the best way to approach our patients. So it's looking at all the imaging. Do they need anything more to give us a better roadmap for planning things? We're looking at pathology, additional procedures to rule out multifocality. Then we make decisions about surgery. If it's just one lesion, yes, I can do it laparoscopically. If we're doing a major tumor debulking and liver resection at the same time, then obviously it's an open operation. And then obviously for the liver disease at the same time, do you do surgery at the same time as the primary, or do you do more targeted treatment? And then for refractory disease, obviously there's clinical trials and PRRT. Thank you.
What's refractory?
Refractory means not responsive.
How do you go about finding and detecting the primary?
So most are found incidentally. Like I said, small bowel, unfortunately, there isn't a way to look for it. So it's really an astute doctor out there who's run, if you have a patient who's had weird abdominal symptoms, diarrhea that is unexplained, has flushing. So part of the problem is that not every doctor out there knows this. I mean, it is extremely rare. So patients present much later because you've had a lot of our patients have had years and years of symptoms. I've had patients who've had flushing and they've been told for years that they were in menopause, and that's why they were having flushing. So it's really just trying to, I think more and more doctors are now becoming more aware. So unlike for other cancers, colon cancer, for instance, you can do a colonoscopy and find things. So double balloons are not done everywhere. Just so you know, there's very specialized centers that do double balloon endoscopies. So we have patients referred to us from outside where they've had, years and years of flushing and diarrhea, and now someone's gone and drawn a chromogranule level that's elevated. You get an octreotide scan done that lights up in the liver, may not light up in the abdomen. Now you got to go look for the primary, and really double balloons is the best way to do it.
Can you back on that? How expensive is the chromogranule A test?
I don't know the answer.
Because it would seem to me that there should be some guideline whereby if a doctor who
Suspects it? They usually do.
So how hard is it to do that test is my question. If that then is something that was never done for Minosia, and then I'm just wondering, I mean, why?
So
why
just
is
remember,
that-
it is elevated in a lot of other things too. Yes, it's a great test, true.
Right, so it could be a false positive, I take
Right.
that, but I mean, so you should think that they have to think that through, but it's
Yeah.
yet another.
But it's
input
considered,
to
so
that.
for speaking from when I talk to primary care doctors or others when my patients are diagnosed, part of it is they think of it as tumor markers, so it's not something in their armamentarium of looking for cancers. I think that's what it is. I think it's purely just an educational thing. And I think the reason we're seeing more and more carcinoids is not just all of a sudden people are just getting it. I think more and more doctors are becoming more aware and more patients are beginning to read about things on the internet as well, saying, I've had years of diarrhea and could this be carcinoid? Yes.
When they talk of the number of lymph nodes to be removed and analyzed, regarding your area of expertise, is it the same for all carcinoids, let's say a lung carcinoid? Is that 12 number still?
No, it's really not. So lung is very different. Pancreatic, there's no guidelines at all. They just say you should have lymph nodes. Small bowel, there has never been. So the guidelines, the NCCN guidelines have only been, and it's really been institutions that push it. So for colon cancer, you could take out 6 lymph nodes and that was considered standard of care. And it hasn't been because there's been so many papers that came out as a result of that showing there was a significant difference in outcomes the more lymph nodes you took out.
What is the feedback mechanism for NCCN to catch up with these findings?
It's publications. It honestly is. There's no other way. You don't just go to them and say, so it's really trying to make them more aware of it. And this was a significant thing for them because it was thousands of patients on it, as opposed to, and that's kind of the reason we looked at it was if you looked at just single institution studies, not everybody has 5,000 small bowel patients, right? The more patients you have that you can prove that it does affect outcome, the more powerful it is. And that's really why sometimes doing these studies where you're actually able to get data from multiple institutions, which is what our data does that. So just remember, the gallium-68 DOTA-PET is only for carcinoids.
Oh, you're right.
It is
So we're
not
showing
for
you-
colon cancer, right? And you want to get your screening colonoscopy because if there's a polyp left in place, 5 to 10 years later, it can become cancer.
And on the second part of that question, you had also indicated that a lot of radiologists don't go beyond a certain point.
Gastroenterologists.
Right, and when I make my appointment, how would I approach asking them if they go, what is the name of the point they're supposed to go beyond?
So to
Yeah.
ask them, can you go beyond my ileocecal valve?
Okay,
Or you can say, can you look at my terminal ileum? I always tell patients who come to see me that have been diagnosed elsewhere by a gastroenterologist, I always say, you need to really thank your gastroenterologist because a majority of them do not do it. They stop as soon as they see the lumen of the
so why do it if
appendix.
they're not gonna go all the way? It's
Yeah.
like,
I mean, it's
Well, isn't
it
it more
takes,
finite
it's
that they have to do
2
it?
minutes. I've asked because all of our GI doctors do it, a majority, I shouldn't say all, but do it, and I've asked them, I said, how hard is it to really go that extra, it's 2 minutes of a procedure.
so it was the
Patients,
valve and the other,
ileocecal valve,
and the other part?
so it's the terminal ileum.
Thank you.
Get it done here. You'll be good.
Oh, yeah, but all my stuff's,
Yes.
yes, UCLA. Yeah.
UCLA does it.
Oh, do you, and they do double balloon?
They
Is
do
that
double
what you
balloon.
do? I mean, that seems to be what I've
Yeah,
heard, that's
yeah.
what you want to request, that you
Yeah.
like a double balloon?
So you only want the double balloon, obviously, if you have a small bowel carcinoid
Oh,
valve.
but
It's
I
not
know.
a screening.
That I know of, yeah. Oh, all right.
No, that's just to find the primary.
So if you have one primary, and when someone's diagnosed and you have one primary, you need to make sure they don't have many more, and that's what the double balloon is. So it's not a screening test just to look for anything, but it's really once there's a
Or
diagnosis,
next.
yeah,
That's right, it's just,
yes.
So if I remember correctly, you said the vast majority of that tumors that occur in the ileum are in the last 2 to 3 feet, basically, that 60 to 80 centimeter?
Correct.
And that of that fraction, a substantial portion are in that first couple of centimeters?
Correct.
Off of, or transitions
Yes.
to the colon? Is it like high concentration of neuroendocrine cells in that
No.
area?
No difference
So
at
they're
all.
evenly distributed
Evenly
all across the
distributed.
GI? It's
Yeah.
just why they occur there is,
Yeah. Yes.
Oh, and in response to the subject you brought up about removing more of the nodes, the lymph nodes, we went to the national conference, and one of the guest speakers, they were kind of claiming their survivalship of their patients that come to them, and this particular doctor was saying that, and it happened to be lung, that he removes like all of them, and his survivorship is greater than any other
Anyone.
institution. Yeah, can someone go back in and do that as a
They can,
secondary
I think,
or-
you know, there's obviously morbidity to going back in for some of these operations, because you can actually do more harm than
More
good.
harm.
The question is obviously if any of those 5 were involved,
They want-
and they weren't, then I don't think it makes sense to put you through something
Okay.
that has morbidity associated with it.
Okay, thank you.
You're welcome.
I wanted to thank you. If you have any more questions, do you?
How's- Yes,
Any more
absolutely.
questions? Okay, and in the meantime, I want to thank you so very much for your
Oh,
time.
thank
Your-
you.
Your information was fabulous for me. And I think for everybody else also, it was so much better understood the way you presented it. And I want to thank you so much for your.
Thank you.
I want to thank you for the people who have come here. And also I wanted to make sure that you knew that the clinical social worker here was Ziva over there. And you please raise your hand if you have questions in regards to your situation. And please feel free to call her. That is what she does for us.
Thank you.
She's very open, and thank you very much. And Drew, I want to thank you for coming and taking the video of this, which is available, and I don't know the name of where it's available, but it's under LACNETS. So at any time you can view the presentation today. And it was so helpful. I just thought it was just wonderful.
So just to give you an idea, this is, I presented to you ahead of time, but this is being presented at our National Surgical Oncology meeting. So all of this is, which is a huge forum for, you know, there's 8,000-9,000 surgeons who just do cancer surgery that come to these. So I think it's important information because it is put out, and they gave us a podium presentation for it, which was good. So obviously the society thinks it's important enough to discuss. Just to give you an idea, 4 years ago, we didn't even have neuroendocrine presented at our meetings. It was really, you got posters, you never got, and now, at the same time, it's like they have the colon, pancreatic, they actually have a specialty session now just for neuroendocrine because it's been such a huge demand for this. So it's great. I think there's a lot of awareness among physicians, surgeons, which is great.
It's absolutely wonderful to have this on a personal level like this. It's unbelievable. And in this setting, and LACNETS is extremely fortunate, I think, for this opportunity. It's unbelievable that you allow us this up close look at our disease. And I think there was another question over there.
Yes.
One quick question.
Sure.
Is Cedars any closer to replacing Dr. Rowland? I'm sure that's asked.
Every month. I think we all would like to.
They are considering somebody very strongly. I think they're just going back and forth. It's a challenge. I mean, I have to tell you, I've been involved with every interview process as well. And I think it's a struggle because that's a neuroendocrine expert, which is not very many in the country, are very established where they are. And sometimes moving to Los Angeles was not part of their bucket list. So it's a challenge trying to get people to
Can't
move here.
imagine why.
Buying a house in
I
Los Angeles
know.
is
I have to tell you though, I did
unbelievable.
speak to Dr. Wolin because Dr. Wolin is involved in 3 of my research projects. So I send him the manuscripts to review because his name is on there. So each week I call him up, you know, and say, Ed, have you read this? And his voice is starting to fade more and more. And then I'm beginning to realize Kentucky has been plastered with snow. He can't even drive to work anymore. So I keep rubbing it into him about how it's 80 degrees here. And he's having to walk to work now because he can't even drive.
And his wife.
So I keep saying, you know, and any time if you'd like to come back.
That's right. It's
Yeah,
Senator Feinstein, not
exactly,
McDonald.
exactly.
I have a quick question. When you've had small bowel neuroendocrine, and will it ever come back there, or does it come back in the liver?
So, the question obviously that a lot of this data now that we're showing with multifocality, which is what we are hoping to address, because our surgery meeting, which is in 2 weeks, is for patients who never had a double balloon. Is there a role to now go back to do a double balloon on these patients, just to make sure that they never did have multifocal disease to begin with that we've left behind? I think that's, a more important thing. So if you only had one lesion or multiple lesions that have been taken out, it usually does not come back to the bowel, as long as the bowel has been completely interrogated with a double balloon. So usually if it comes back in the liver. The question is really that we all have to address is, do you put patients now through this double balloon just to make sure we haven't missed anything for patients who never had it?
Is it dangerous to do the double?
Sure, there are risks of the procedure, so you can get perforations, and obviously if someone's had surgery already, and now you've developed all the scar tissue, and you're putting a scope through this, it does become, there's obviously a risk of perforation, so yes. It's a question of balancing.
What about that scar tissue? How much does that impact things? Is it always a problem for people with scar tissue?
Yeah, anytime you have surgery, just so you know, even if you go in and take an appendix out, you develop scar tissue. So part of it is when we go in as surgeons, we're always looking for things as well, for small bowel, even though we're just operating in one area. Like I said, we still run the entire bowel. So I pull the entire small bowel out of the abdomen, and then I run it very, very carefully. And doing all these things, you develop scar tissue. So anytime you go and touch something and move things, you will develop scar tissue. And then obviously when you're going through procedures, it becomes much harder. So even if you're getting a routine colonoscopy and you've had a hysterectomy done as a woman, it does become harder purely because the rectum and the last part of the colon, the sigmoid is down there, and it becomes scarred in. So gastroenterologists sometimes have a hard time just navigating that area just to get through the scar tissue when it was just a hysterectomy.
Does it improve over time, like scars that you
It
see on
can.
your skin do improve?
Some
Does
do,
it
and
improve?
some it just gets worse and worse with time.
Okay.
And there's, patients, when I've operated on patients for bowel obstructions from scar tissue, they always say, well, what can you do to prevent this from happening again? And there really isn't anything. We have newer things that we can lay on the abdomen when we close to prevent that, but there really isn't anything that you can pour in to prevent these from happening, unfortunately.
Yeah, I wish you guys could put those
I
things
know.
back the way they
I
came
know,
out.
exactly.
Life is
We
never
all
the
do,
same.
yeah. Absolutely. Perfect. Well, thank you so much.
Thank you.
Thank you.